All right. Good morning and welcome to our last webinar of this year NLAAD campaign, the HIV Care Cascade in the USA. Before we begin, housekeeping, everybody who will log in is going to be automatically mute. The webinar is being recorded. It's going to be posted on our website and social media as well. There's going to be a time for questions and answers at the end of the presentation. Please write your questions in the Q&A box. And when you finish the webinar, you will receive a link for a survey for the webinar. Please fill it. For us, it's very important to give the information. And my name is Luis Alberto Mares. I am the Director of Community Mobilization Programs at the Latino Commission on AIDS based in New York City, but we reach to the entire country. You can see here one of the posters that we have for this year campaign in 2024, which we focus mostly on treatment. Last year was prevention, today is treatment for HIV, and also the challenges that the population living with HIV have to reach the Latino population, to reach access to care and treatment. And this is going to be presented today. It's very important because it's linked to these challenges that the population has, linked to access to care, to medical care. And you're going to see how this affects the cascade. NLAAD was created 21 years ago by the Latino Commission on AIDS and the Hispanic Federation with the purpose of addressing the impact of the HIV epidemic among Latinos and to create awareness and promote HIV testing. With the years, we have increased the goals of the campaign is not only to increase testing, but also to increase awareness, prevention, and link to treatment. The importance of private PEP treatment, the importance of rapid treatment, the importance of adherence of reaching undetectable levels for allowed, and U equals U as well. All this represents the HIV care continuum that today Dr. Patrick Silva will present on this webinar. HVU works with data that is collected from all the countries through CDC and produces incredible reports about the epidemic for county, city, state, and region. Dr. Patrick Sullivan is a professor of epidemiology at Emory University World School of Public Health and the principal scientist of HVU. Dr. Sullivan has 22 years of experience in HIV epidemiology and prevention in men who have sex with men in the United States and in international settings. He worked in the Centers for Disease Control, CDC, for 12 years, including service as an epidemic intelligence service officer, a branch chief, and acting deputy division director in the division of the HIV/AIDS prevention. He also has experience in design and oversight of biomedical prevention trials, having served as the associate director of scientific support for the NIH-funded HIV vaccine trials network. He's currently the PI of several NIH-supported research grants to develop improved methods for online HIV prevention studies. Dr. Sullivan holds a PhD in comparative and experimental medicine and a doctor of veterinary medicine from the University of Tennessee. So, Dr. Sullivan, you can go your presentation. Also share yours.
Oh, sorry. Thank you so much for that introduction and for an opportunity to share some information today about the HIV Care Cascade. I'm going to share my slides. And be that. There we go. So thanks for this opportunity to talk about the Care Cascade and really to focus in on Hispanic, Latinx, Latinx communities. And I'm going to be talking some about the Project AIDSview, but really as a way to get at the kinds of information that I think are critical to our shared goal of ending the HIV epidemic and doing it equitably, which I'll try and focus on during the talk today. So I just want to start out by giving you a brief overview of what AIDSview is, the history of AIDSview, and most importantly, how we've tried to set up the site so that different stakeholders, government, community, medical, support services can use the site to try to accomplish their organization's goals in ending the epidemic. I think we all have a sense that it's going to take multiple organizations working from a shared platform of knowledge and with a shared vision and goal to really bring this epidemic to an end. So AIDSU is a partnership that has been in existence since 2010 between Gilead Sciences and Emory University. And the concept behind it is really illustrated in this slide, which is I worked at CDC for a number of years in the HIV surveillance program. And in that work, the state and local health departments collect all this important information because we can't end the epidemic if we don't understand the epidemic. And really, public health surveillance data are meant to give us that tool in ending the epidemic. And at the time that I worked at CDC, we often presented data like you see this page here, which is a line of cities and the number of cases and the rates. And I think some people consume data in this way, and tables like this make sense to some folks. Other people are visual learners, and even within my own family, my son is very much of a visual learner, and the parents are both quantitative. So what our idea was to take these really high quality data that represent the work of your colleagues and our colleagues in state and local health departments at CDC and turn them into a way that could tell a story about the epidemic and let people understand in a visual way and for me in a really motivating way, what's going on with the epidemic. So the goal here is to make the data widely available, easily accessible. That means online and free, but it also means accessible in a way that I and others can understand it, and locally relevant. So looking at state level data is helpful, but looking at state level data doesn't really tell you, if you work in a state health department, what to do within your state. And so the map you see here goes down to the county level. And we know just from user surveys and where people log in from that this is used by public health officials, policymakers, advocates, researchers, people living with HIV, and the public. And we'll talk some more about this going forward. So we started in 2010 with just those state level maps up on the top here, which themselves tell some kind of story, but within a year moved to this county level map where you can start to see yes, the high impact in the southern United States, but also the impact in rural areas. In 2011, we also added cities. And through the years, we've added new diagnoses, care continuum elements, viral hepatitis on a separate website, HepView. In 2018, we started providing state or PrEP data first at the state level, then at the county level, and in 2020, enhanced care continuum. So who uses AIDSview? We try and put the site together so that it spans a range of folks. So researchers, definitely a source of data and downloadable data for academic researchers. And as I'll show you later, we have a place for experts, not just academic experts, but community experts, prevention experts, state health department experts to share their voices and their work. And so we have these maps, which are hopefully accessible, broadly, data sets, which some people like to download and analyze, and then some technical information about how the data are derived. For lawmakers, these information are really relevant at the local level. And we know that there's been a lot of use of AIDSview to sort of even print off these state level fact sheets. And people have used them to talk with their policymakers and in policy forums to help those who are considering laws that might actually help our efforts to end the epidemic understand the impact, in that state, in that district, and really bring home the impact in specific legislative jurisdictions. And then for public health officials, who are really the people who do so much to our collective work to end this epidemic, it also sort of takes some of the legwork out of being able to compare multiple sorts of data. They're experts at data in their own states, but AIDSview allows them to compare, for example, if I work in a southern health department, to compare apples to what's going on in other southern states. Is there another state that has a similar pattern of morbidity or a similar rural concentration to my state that I could reach out to and say, hey, it looks like we're dealing with the same things here. And then the data sets get quite granular. down to the census tract level in some cases. Importantly, we want advocates to use AIDS views, data profiles, and maps to support advocacy activity. So we have a feature that allows the overlay of congressional districts, and this is helpful for people who want to talk to their representatives about what's going on in their districts. I think policymakers are often most receptive to action when they understand how the district that they represent is impacted. And as much as possible, we try and make these things downloadable, understandable, because advocates have such a critical role to play and such important relationships and skills. And so we want to make the tools to support that work as sort of ready to go and downloadable as possible. For people living with HIV or at risk for HIV, we have service locators where people can go to find HIV testing, treatment, and care. And for the public, we have infographics and Q&As, which I'm going to show you some of later, that really help try to communicate data about this epidemic in a way that's clear and accessible. And I think HIV is a complicated topic. Many of us work in this day in and day out. But for the public, I think messages that communicate key aspects of the epidemic clearly can be helpful to sort of bring along our advocates and our supporters who I think when they understand what's going on in the HIV epidemic are important allies. And finally, for awareness days, we try to recognize the multiple communities that commemorate awareness days with content that's really specific to those varied demographics, and we'll see some examples of all this. So race ethnicity plays such a key role in the HIV epidemic in terms of the disparities by race and ethnicity, and in terms of the need for resources in the communities that are most impacted. And so this just gives you an idea of the data elements for which we have race ethnicity broken down. And that's HIV prevalence at city, state, and county levels, new HIV diagnoses at city, state, and county, HIV mortality, city and state, HIV testing by race ethnicity only at the state at this point because of the limitations to data sources, the care continuum for all three, and then PrEP use currently focusing on the state level. When we talk about data by race ethnicity, on the website, you can actually look at, for example, the national map and then select to just see Hispanic ethnicity. And the view that you see is limited to, in this case, the number of people living with HIV by county across the US. And this is the same view at the state level. And not surprisingly, I think we see this concentration, especially in the US South and New York. And then the infographics will display this comparatively. So we may want to know, for example, within a jurisdiction, the proportion of the population that is Black, Hispanic, or white, and then the proportion of HIV cases, for example. And so these are all laid out for all these indicators by race ethnicity with the population proportion and the proportion in the epidemic. And in many cases, we see for both Black and Hispanic Latinx people that the impact of the epidemic is greater in the population relative to the overall representation of Black and Hispanic Latinx people in the population. So I just want to bring us back to the care cascade, which is, I think, one of our important roadmaps to the goal of ending the epidemic. And this is called the diagnosis-based continuum of care. The concept here is that that when people are living with HIV, we have a series of goals that depend on each other. You have to go through step one before you can get to step two. And here is depicted late diagnoses. And this means people who were living with HIV and actually had an AIDS diagnosis within 3 months of being diagnosed with HIV. So they were likely living with HIV for a long time, had opportunities to learn of their diagnosis and take medications to improve their health, and maybe miss some of those opportunities. Then linkage to care is about 82% were linked to a healthcare provider, and had testing within a month of being diagnosed. Received care is receiving medical care and within the year, and virally suppressed is the proportion who were living with that suppressed viral load. And it's important just to remind us ourselves that one of the real, I'll talk about this again in a minute, but one of the really critical scientific understandings and prevention understanding that has emerged is the concept of U equals U, that when people are in this column of being virally suppressed, that people living with HIV are incapable of transmitting HIV to their partners. I think that goes a long way towards prevention, but it also goes a long way to some of the stigma that can be associated with living with an HIV diagnosis. And so I think focusing on viral suppression as both a clinical important outcome for people living with HIV, but as a prevention and as a public health outcome is also important. So the Ending the HIV Epidemic is a plan that was announced in 2019. And the goal is to end the HIV epidemic in the United States by 2030. Absent development of a cure, that might most reasonably mean to stop new HIV infections and to make sure that the lives of people living with HIV are extended to a normal expected lifespan. An agency across the Department of Health and Human Services have an operational plan for this, and there's additional funding and requests for more funding associated with it. The plan is really based on the fact that science has advanced so much in each phase of this sort of process of diagnosing folks, treating folks, helping people who are not living with HIV today prevent infection, and responding when outbreaks occur. And initially, the initiative focuses on areas where HIV transmission is occurring most frequently. So this is 57 focused geographic areas in the United States. And those areas are going to get additional resources, additional expertise, new technology. And they really are asked to develop a locally tailored plan. It's not a one-size-fits-all. It's meant to draw on local data. And we really hope that AIDSview can be a part of that process, along with the important information that comes from the health departments, that AIDSview can be a source of information as those local communities meet to decide how they're going to do this work in their own communities. The goal here is to reduce the number of new HIV infections by 75% by 2025, and then by 2030 by 90%. And that would avert over 250,000 HIV infections if we can accomplish that. So I mentioned that initially this is starting in 57 priority jurisdictions. That's 48 counties plus Washington, San Juan, and these comprise more than half of new HIV diagnoses. And then there are 7 states that have a disproportionate occurrence of HIV in rural areas, which we already saw in that AIDSview map where we saw the U.S. South. So these goals really that you see on the slide really correspond with the steps of the HIV care cascade. So it goes right along with this, which is diagnose infections, and on the far right would be the indicators that we could look at in AIDSview. So we can look at diagnoses, we can look at knowledge of status. For treatment, it's important to have linkage to medical care, and the goal here is viral suppression. For prevention, that really we monitor that with an indicator of PrEP coverage, and all of these have data available on the site. So one of the areas of real focus for us is health equity. And I think we talk a lot about health equity these days, which is great and important. And I just want to pause a minute to think about what this looks like in the context of the HIV epidemic, and how we share these data in hopes that you can use them to advance these conversations. And health equity has been defined as that state in which everybody has a fair and a just opportunity to attain their highest level of health. And so that it's important to say that the reasons that these inequities occur, although they often occur along racial ethnic lines, are not about race ethnicity. They're about chronic exposure to racism and xenophobia. And that means that to address inequities in health, we're going to have to think more deeply in society about how to address those historical and the contemporary injustices, but really get and specific and call out the economic barriers, the social barriers, and the other areas that are put up to accessing health and healthcare. And if we do that, we can really make progress towards eliminating preventable health disparities. And there has been progress made since 2018 when those EHE goals that I mentioned were established. But unfortunately, that progress hasn't been fair and consistent or even across the demographic groups. For example, although HIV diagnoses have been decreasing overall since 2008, there's been a 42% increase in new HIV diagnoses for Hispanic, Latino, gay, and bisexual men during that period. That's just an example where the overall trend looks positive, but the impact in the specific group of Hispanic, Latino, gay, and bisexual men going in the opposite direction. So if we think about walking through that care continuum, I'll orient this to you and then we'll look at a few slides. So in terms of new HIV diagnoses, this is the national map. Darker colors indicate larger numbers of new diagnoses. This is for 2022. And we're going to go back again to this idea of Black, Hispanic, and white. And we also have Asian, multiple races, American Indian, Alaska Native. But if we just sort of focus, for example, on Hispanic and white, you can see that white people constitute about 59% of the US population, but accounted for 27% of the new HIV diagnoses in 2022. And Hispanic people, conversely, comprised 18.7% of the new diagnoses, but represent of the population, but represented 25.7% of the new diagnoses. So we have this sort of spread between, an equitable epidemic would say if a group is 19% in the population, they should represent 19% of the new diagnoses. And instead, we see these sort of mismatches between the population prevalence. And then just to note again that since 2008, there's been this really remarkable increase, 42% increase in new HIV diagnoses for Hispanic and Latino, gay, and bisexual men. And I think that's important for us to keep front of mind. The next step is getting diagnosed promptly once living with HIV. And late HIV diagnosis is that situation where people are diagnosed with HIV and then who acquire HIV and then aren't diagnosed with HIV until they are within the sort of clinical state of AIDS. They have a very progressed state of disease. And ideally, we'd like for this number to be as small as possible. In 2022, there were 7,863 people who had that stage 3 late stage within 3 months of initial diagnosis. That means there was a long interval between when they acquired HIV and when they were diagnosed. And you can see the distribution here and the numbers as far as by race, with 19.9% for Black Americans, 21.3% for Hispanic, and 21.4% for white. Moving on now to linkage to care. Once someone is diagnosed, the goal is to have people move into linkage to care and as promptly as possible, hopefully within 30 days of the new HIV diagnosis. And when we look at the map here, this is the percent of those who are linked to care in that time period, focusing on Hispanic people. And this darkest shade means that 84% or more of those in that group were linked to care within that interval. So overall, nationally, that number is about 81.6. We're aiming to get to 95. And in 2022, the Hispanic Latino people who were diagnosed with HIV, of Hispanic Latino people who were diagnosed with HIV, 85% were linked to care within that interval. Next is receipt of care. So once someone's linked to care, we want to see that they've had at least a CD4 or viral load test that run by their healthcare professional. And this really means that people have gotten to care and have gotten that clinical assessment that is the clinical staging and is the entree into treatment. So this lets us see whether people are actually getting the care that's going to be life extending and get them to that state of undetectable. And here the number is a little bit lower than average. For Hispanic, it's about 76% compared to 82% linkage. And for Hispanic, Latinx, Latina individuals, only 73% of those diagnosed had received care in 2022, which is lower than the national average. So this indicates that there's sort of a gap for this Hispanic Latinx community in terms of being linked to care and then getting into that care and treatment. And although the percentage is pretty consistent across the country, there is some variation with some states that seem to be doing better and some states in the U.S. South that seem to be lagging behind. And so those are areas where we should be asking questions about what can be done better. And then the last piece here is viral suppression. Viral suppression is such an important goal because most importantly, we know that people who who are living with HIV and have a suppressed viral load have lifespans that are the same as people who are not living with HIV. So people can live long and healthy lives. And this viral suppression is sort of the clinical indicator that someone has a good control of the HIV infection in their body. And then I'll talk again a little bit more about U equals U. So the benchmark here is like having less than 200 copies per mil of HIV in the blood. And this is accomplished by taking antiretroviral therapy. And the goal for the 2025 goal for viral suppression and ending the HIV epidemic is 95%. And where we stand today, we're pretty far short of that. About 65% of people living with diagnosed HIV have that state of viral suppression. And for Hispanic, Latinx, Latina individuals in 2022, that was 64.3. So a little bit lower than the national average. Again, we see this variation in the percentage virally suppressed on the map in shades of red here, where darker red indicates higher sort of viral suppression levels. You're probably picking up a pattern here, which is there are a number of states that seem to consistently do better on all these benchmarks, and the U.S. South particularly has tends to be sort of in the lower of these the lower end of these 5 categories. So I want to take a minute and really emphasize the idea and the importance of viral suppression in U equals U. And although this is a relatively recent piece of science, I think that the HIV community embracing it sort of wholeheartedly and using this as a primary prevention strategy is coming into its own and needs to continue. So that viral suppression is the last step in the HIV care continuum. So that process we saw before, this is the end. So people have to be diagnosed in order to get into care. They have to get into care. They have to get treatment. And then they have to adhere to that treatment. And treatment has to be effective for them to reach an undetectable viral load. But once that is the case, people living with HIV are incapable of transmitting HIV to their HIV negative partners. And this has important implications, as I said, for prevention, for quality of life, for quality of sex life, and for reducing stigma for people living with HIV. And we can think about this at the individual level, which is that 200 copies per mil of HIV in the blood, but we can also think about it at the community level. So, can we aspire as communities to say, we want to put such good services in place that among members of our community and our families and our neighbors who are living with HIV, that we reach a state where we really are lowering the chances of transmission among members of the community. This is a treatment as prevention strategy, and a CDC analysis showed that 80% of the new HIV infections in the U.S. in 2016 came from about 40% of people living with HIV who either didn't know they had HIV or knew they had HIV but weren't receiving care and treatment. And again, I want to emphasize that when we say, like, here's someone who knew of their HIV infection but weren't receiving care and treatment, that is, I think that is a question that we need to look carefully at the social determinants of health and what are the barriers that our culture and our society and our medical care systems are putting in place, and where the opportunities for us to do better in lowering those barriers. I think it's important that this not be a blame-based conversation, but a conversation of opportunity. So this is an idea of trying to make the response to the HIV epidemic be less about categorizing people into you're either living with HIV or you are not living with HIV, and like putting us all on the same page here and saying, we have a shared goal here, which is to end the HIV epidemic. So let's talk about how we do that in a way that doesn't make these distinctions so dramatically. So if you think about this, there really are a number of things that we have to consider in terms of ongoing to access and to prevention and care. And so for people who happen to be not living with HIV, this is really about the same kinds of things: taking tests, getting results, getting the right prevention or care services, getting a prescription. Maybe it's for PrEP, maybe it's for ART. Being adherent to those medications if you're on PrEP or using post-exposure prophylaxis, or being adherent to those medications if someone is living with HIV and is going to be virally suppressed. And dealing with taking of long-term medications, and with the questions that come up and with the challenges to getting our medications and keeping them in our homes and all these things really require ongoing maintenance of support. But if we stop making such a distinction and say, like, we're doing something completely different for people who are not living with HIV, and then we have a separate set of concerns for people who are living with HIV, they're actually the same kinds of steps. The prevention is largely based on the same medications and classes of medications that help people achieve viral suppression. The needs to support taking medication over time are the same, whether it's PrEP or treatment. And then this piece that I mentioned before, these sort of social determinants of health, also come into play. Because if you don't have transportation, it's going to be hard to keep your PrEP appointments, to pick up your PrEP pills, or to pick up your treatment, or to make your treatment appointments. If you don't have a stable place to live, there are challenges that people have with just being able to keep their medications in a way that's private and accessible if they don't have that private space. Substance use can complicate any of these efforts to take care of ourselves, and to complicate the efforts of providers to help their patients be in good health. So this model from the New York City Department of Health and Mental Hygiene sort of says, let's just think about this in a way that recognizes that people live in different health states, which is true in all kinds of ways, but doesn't make a separate picture for people living with HIV and living without. Let's say that we're all in this together, and it's just a matter of specifically which tests and diagnostic tests we need, specifically what kind of antiretrovirals we might be taking for prevention or for treatment, and specifically our outcomes, which might be adherence to PrEP or to treatment. So when we look at this sort of care continuum in Hispanic, Latinx, Latina communities at the county level, all these maps are available on AIDSview, and we do again get a sense in some ways of the places where there are bigger populations of Hispanic, Latinx, Latina communities. When we get down to the county level, the counties that are grayed out are grayed out due to privacy concerns. Like if there is less than a certain number of Latinx, Latina people in a jurisdiction, we won't report just because of concerns about indirect identification. But here is this map represents the number of people newly diagnosed with HIV. You can see concentrations in California, in Texas, in Florida, and in the Northeast. This is the percent of people linked to care in a timely way in 2022. Again, the same sort of regions are populated, but the shadings here give you an idea of where that's happening promptly, which is the darker shades of green. This is the percentage of people who are treated. And I just point out that in the South, and this is this is specific to Hispanics, Latinx, Latin people, that we have these areas largely outside of rural areas or urban areas where the shades are quite light, which means there's a high proportion of people, Hispanic, Latinx people in these areas who are not, receiving that HIV care. And then here we would like to see every county be this darkest red shade, which is viral suppression. It's that state where my lifespan is statistically the same as if I didn't have HIV. It's that state where I'm incapable of passing HIV to another person. But again, we see these areas of opportunities to do better are the lighter pink. And just in a broad brush, these are often occurring in the South and in areas that are more rural rather than urban. I just want to reemphasize, and again, all these data are available for your own use and your own consideration. But these are the social determinants of health. These are the things we talk about. This as the conditions where we live, learn, work, and play and worship that actually have a big impact on our health risks and outcomes, not just for HIV, but for all kinds of health outcomes. And so there are these key areas that we want to understand. So if we start down in the lower right-hand corner here, you can just see the proportion of people living in poverty. And I've been pointing out these sort of regions that run through the South, where we saw some of those care continuum indicators having gaps in those care continuum indicators. And some of those same areas are the ones where we're seeing high levels of poverty, people living without health insurance. I would just point out, like, the state of Texas here is sort of a big hotbed of people living without health insurance. And there are really policy solutions that help this. Medicaid expansion is shown to greatly improve this indicator. So these are some things we can be talking about with our policymakers about, and taking these kind of AIDS view maps to our policymakers and just say, like I live in Texas. Why do we look like this compared to the rest of the country? What's going on? Why can't we do better than that? This is income inequality. Again, where we'd like to see like lower income inequality. And this is on the top right is the percent of the population with severe housing cost burden. Again, not surprisingly in California and the Northeast, but secure housing is such a critical aspect in terms of our ability to get engaged with and stay engaged with healthcare. So I want to just wrap up by talking about equity in a little more specific way. And we talk about health equity a lot these days, but it really, I think, has kind of a specific meaning, which is, as I've been showing, that Black and Hispanic, Latinx, Latin communities are disproportionately impacted by the HIV epidemic in each of these stair steps of the care cascade. And equity says, if a community has, for example, twice the risk of acquiring HIV as some other community, then ideally we'd like for that community to have twice the access to an intervention like PrEP, which can prevent the transmission of HIV. So if my community has twice the risk of acquiring HIV, my community should have twice the opportunity towards PrEP. And so PrEP to need ratio just sort of asks whether that's really a fair allocation of a resource like PrEP. So PrEP is so important because really the timing of the introduction of PrEP has gone along with the decrease in HIV diagnoses over time. And we know that states that have a higher level of PrEP coverage actually have bigger decreases in their rate of HIV diagnosis. So at a state level, there really is an association between what percent of people who would benefit from PrEP are getting it and the extent to which new HIV diagnoses are coming down. And so, but there's a lot of variation in that metric, which is how well are those PrEP needs being met. If you take the 10 best states and the 10 states with the most opportunity to improve in this country, there's an 8-fold difference between the extent to which that PrEP need is being met. So we have a lot of opportunity here to do better. We know that when states do a better job of getting PrEP to the people who need it, that the HIV diagnoses in those states are more likely to be headed down. So in Hispanic Latinx communities, there are some of these structural barriers that we talked about before. We can look at this as sort of a measure of PrEP equity. And what we find is that, as I said before, if a group represents a certain percentage of new HIV infections, if I'm 50%, if my group is 50% of the HIV infections, we'd like for that group to have 50% of the PrEP. In this case, Hispanic Latinx people represent about 31% of all new HIV diagnoses, but only 13% of the PrEP use. So if it's got equity would say 31% of the diagnoses, 31% of the PrEP users. In reality, we have 31% of the diagnoses, only 18% of the PrEP users. In contrast, white non-Hispanic people represent 24% of new HIV diagnoses, so should be getting 24% of PrEP, but white non-Hispanic people actually get 64% of PrEP users. So this just means there's greater unmet need for PrEP in Hispanic Latinx communities than in white communities. Ideally, we would like to have PrEP for everyone who might benefit from it, but we need to be mindful that because of these social determinants of health, that there are greater barriers in many communities, and we have to think about this as a health equity issue, and understand what's happening in our own community. For example, in the West, that sort of number is Hispanic Latinx people representing 50% of new HIV diagnoses, but only 24% of PrEP users. So I would look at this at your state level. You can find all these data on AIDSview. If you want to have this discussion with your health department or your policymakers, you can also, and you're having trouble finding something, you can email us at help@aidsview.org, and someone will get back to you and help you find what you need to have those discussions. So I just want to point out a few other resources. So wherever we are, wherever we find ourselves in the HIV epidemic, and we may have multiple roles as people who are living with HIV, as people who are not living with HIV and taking PrEP to prevent that occurrence, or but also as providers or as a provider living with HIV. So we have multiple roles in this effort, and so we need to just be informed about our own local environment. So on HIV, you can find HIV service locators. You can look, for example, for this is testing. This happens to be Atlanta. So this may be to find a place to test for HIV yourself. This may be a place that you point clients to. This may be a place that you sit with clients and help them find a place and get directions to some place that would be a convenient location for them. This also works for PrEP. This also works for HIV treatment. We also have expert Q&A blogs, and so these come out, usually once or twice a month, and they have to do with specific topics. And so here is Dr. Areola on health inequities among Hispanic Latinx populations, and Luis Mares on the impact of HIV in Hispanic Latinx people. And then we have these infographics like the ones we've been looking at, which focus on Hispanic Latinx communities, which we try to offer in both Spanish and English. And you can use these for your own sort of knowledge. You can use these to share with policymakers, to have discussions, and to try and help us work together to focus on these problems. And then we have something called Deeper Looks, and these are areas of the website where we really compile a bunch of, a number of types of information about specific issues. So there's a deeper look page on transgender people living with HIV, criminalization, health equity, HIV testing, HIV in Black communities, HIV among Hispanic, Latinx, Latina people, the South, PrEP, ending the epidemic, care continuum. And you'll be able to find here maps, these Q&A blog posts, data. If you want to talk about HIV in the South, you can go here and download some infographics that are the most updated and can really tell that story. So we are going to spend some time with questions. I really appreciate the questions that have come in. I haven't been able to read them all as they came in, so I'm going to just take them in order. And I'm just going to pause for a minute to see if there's any other sort of moderation. And I think we're happy to share these slides. Joey, Emilio, I appreciate the late diagnosis data being simple to read and understand. That's one of the nicest compliments you could give, because these data can feel complicated, but we try and put them out in a way that people can sort of take them in. So is there a state ranking available for new HIV infections? Yeah, so I think what you could do is just look in the colors. You can find all of these data in spreadsheets, and so you can just sort the spreadsheets. But this group of sort of Florida, Louisiana, California, just by counts, and some of the states in the Northeast. But you can actually, get the sort of, highest to lowest list by downloading the spreadsheet of data and seeing it. Talk about filtering data for smaller groups to identify increases in smaller populations. For example, California recently dissected data to focus on cisgender women, and we were able to see an rate increase in Latina women by 24%, and in women with IDU diagnosed by 8%, and 100% increase in women with IDU aged 25 to 34. What can we do to uplift these inequities in smaller groups? So Francisco, thank you for this question and for this example. We try to make this as easy as possible on the website. Once you're on the website, you can actually select different groups, and you can compare different groups in side-by-side maps. The principle that you're talking about here, which is that it really, like, even talking about women in California or cisgender women in California is an inadequate way to understand where the inequities really lie. And the way I sometimes think about this is we are all, each person, if you think it's like a star of these lines coming in, and where we intersect, like where people's reality is an intersection of a lot of characteristics of ourselves. And so, for example, you're talking about women who also have the behavior of injecting drug use and are in this age group. And so I think I would encourage people in their area of interest, if your area is California and specifically in Latina women, you can go to the website and sort of zero in, look at the maps, see what questions you have, and then sort of dive deeper, and then the city or county profiles will have more details about those breakdowns. So it is a process of trying to figure out that sort of branching tree and identifying those groups of people that might have particular risks. And then what can we do to uplift these inequities? I mean, I think the first thing is to talk about them in the exact way that you are, because I think we have a tendency to think in more broad brush, perhaps, about communities at risk, or talk generally about, like, gay and bisexual men are at risk, Black Americans are at risk, Hispanic, Latinx, Latina people are at risk, but really we all are intersectional, and so the prevention needs of Latina women may be quite different than the prevention needs of Hispanic, Latino, MSM. And so we have to think about prevention also in a way that's intersectional and just the way that you are. And again, our hope is that by giving people the ability to sort of drill down and understand this, and I think maps are sort of a common a good pathway of starting discussions with people who may be more or less quantitative. Like I said this in the beginning, members of my family who, if you show them our son, if you show him numbers, he doesn't want to see that. He like takes information better in a picture. So the last thing I'll say, I think it's all the questions that are in here. But as we wrap up, I just want to say AZU is a website, but we're also a resource, and we're also a team of people um, who who are dedicated to the work that you're doing and to facilitating ending the epidemic. So you can always reach out, you can always ask and say, like, I'm trying to address this, group. I'm trying to address providers. I'm trying to address health department people. I'm trying to address, community members and around these issues. We can help point you to some things that we may already have made. We can, if we know that someone else has something made or not, like another resource, we live in this world and are in it every day, so we can try and direct you to that. And I guess I would just close by saying, I mentioned that I started working at CDC in the HIV surveillance program, that we made those surveillance reports with those columns of data. And my passion around this is the government invests and the state governments invest a lot of money in public health surveillance. There are a lot of people who could do all kinds of work and who choose to dedicate themselves to having this information exactly so that we can make health better. And there's this last step of taking those data that are in tables and figuring out, well, what do we do? What are we going to do today that makes things better for people, that helps improve the proportion of people living with HIV who are virally suppressed, that prevents the next HIV infection? And my passion around this is that everybody ingests those data differently. And if you're one of the many people, probably the majority of this country, who take data in not as tables but visually, we're here to try to make that happen and support the thing that you're passionate about, the expertise that you have, the opportunity that you have to help prevent HIV preventions in our communities. We're here to support that. And so I encourage you to, surf around the website, reach out to us if you have questions. If we don't have the information that you need, we may be able to connect you with somebody. But I think the more we all educate ourselves deeply about these aspects of the social determinants of health and the environments and just the layout and the geography of the HIV epidemic, the better equipped we are to be targeted and responsive and effective in ending the HIV epidemic. So I want to thank again the Latino Commission on AIDS for hosting this webinar. Thanks to all of you for coming, for the questions that you've asked. We will share slides, and if we can ever be helpful to you in the work that you're doing, please don't hesitate to reach out, because we are here and that's why we're here. So I'll turn things back over. Thank you.
Thank you, Patrick, very much for this important presentation as well. Every year, if you bring data that is very important for the epidemic and for the people that work in the epidemic, like all of us doing this job. Thank you also for Kathleen for coordinating this. And thank you all of you for attending today's webinar. And this is the last webinar of the year for NLAAD. And we will be having another set of webinars next year for the campaign in the September, October next year. So with this, I'm finishing. I just want to encourage organizations that work with us to continue promoting testing, to continue promoting prevention, to continue working on in linking people to treatment and educating them to adhere to the treatment. You see the importance, how important are all these pillars of the epidemic for us to reach the goal that we have in 2030. We also want to say that before the pandemic, we used to have many events happening for NLAAD. After the pandemic, we all decreased because everything went virtual and people don't do meetings anymore. So I was want to encourage organizations to please go back to those times when we were having events for NLAAD, and we use testing yourself or we partner with some other organizations that do testing, promoting PrEP and linking people to and in the event, linking them to treatment and things like that. So we can have again the impact that we had before. I mean, I know NLAAD already launched as its own, and people do their own events on their own. We would like to also, those who do events, let us know they're doing events so we can count them in our report. Thank you very much. And we'll see you again for NLAAD next year, but we may for NHAT. We'll see you again. And thank you, Patrick. Thank you, and thank you all for your attendance today.